distinct pleasure to invite our next speaker, Professor Deepak. He's a world authority when it comes to the glaucoma as well as a pathology. Sir will be giving a lot of insights about each of these conditions. Thank you, sir.
Thank you, Dr. Murli, for inviting me to give this talk. So I'm going to speak a little bit about the pediatric cornea from the pathology perspective in health and disease, and give you examples of some of these diseases. So we'll briefly touch on embryology and some of the conditions we've already spoken about and look at the conditions from a pathologist perspective. So I think this is kind of a revision of what we've known, but where the cornea arises from, remembering that the epithelium comes from the surface ectoderm, rest of the cornea mostly from the neural crest. And then in the fetal cornea, you have multiple layers of epithelium as well as multiple layers of endothelium. There's, physical dimensions of the cornea are well known in preterm, term, and young infants. But the sad part is we really don't know anything, very, very little about the responses, the composition, the molecular pathology of the pediatric cornea. It's a huge gap in the literatures, and I think that's one of the reasons we don't understand a lot of things of why these corneas behave differently. And this is a stimulus to people to try and look at it. We have the tools available today to look at these very easily. And I think it's worth looking at, and I think it'll help in managing many of these conditions that we see as the pediatric cornea specialists see. So many causes of pediatric corneal opacification, and we've talked about this a lot. So I'll show you some pathology. So there are two cases here. The first one is the one up there. This was a painful blind eye, actually from the University of Illinois archives from the 1930s. And you can see your stromal cleft that you see there. There's no decimase. That's actually the lens capsule sitting behind the thin cornea here, right? And that's the lens there. So this eye was a very interesting eye. This actually I saw about 10 years ago as an autopsy eye. Someone called me from the autopsy lab saying that there's a corneal opacity. And it was a rare chromosomal abnormality with Peters anomaly. So it shows a lot of interesting features. Of course, the lens is stuck behind the cornea, as you can see. Decimase ends kind of somewhere like here. And then there is this peculiar accumulation of cells right here in the center, where there seems to be an arrest of the cells not being able to migrate centrally. So I think one of the ways Morley and others have looked at this condition is to kind of perturb these cells and see if you can, they can lose their contact inhibition and grow across that defect and cover that, and that may be the basis of these cells. What makes it stop here, we don't know. The second feature I want to point out, as Dr. Sushmita had said, is to look at the angle here, okay? So here is the iris, like most congenital glaucomas, the whole ciliary body complex is often moved forward, right? And then you see no trabecular meshwork, and you see no Schlemm's canal in this baby. So this is probably one of the reasons why classical procedures don't work that well in some of these patients, and this is a high magnification of this particular view. Sclerocornea is another interesting condition. I think we've touched on it. I'll touch briefly on the pathology, and it's kind of fascinating. I mean, it looks like sclera, the cornea. And if you look at, this is a normal cornea and some sclerocorneas. Bowman's is absent. The corneal stromal collagen kind of is irregular, thickened, looks like sclera, right? It looks very much like sclera. And the cells are a little paucicellular compared to the normal cornea. But then if you look at the immunophenotype of the cornea, so the main glycosaminoglycan produced by the normal cornea is keratin sulfate type 1, right? And this expresses normally. So you have, it is really cornea, but the assembly of the fibers of the cornea are like sclera. So the scleral immunophenotype is not there because sclera contains different molecules, and but it's really cornea which behaves like sclera because of this. We know it because of the keratin sulfate content. So we've seen several cases like this and published several case reports on different types of sclerocorneas, and the immunophenotype is very similar. CHED, as you all know, is again a condition where you have loss of endothelial cells from these genetic mutations. And one of the hallmarks of CHED, of course, apart from loss or attenuation of corneal endothelial cells, is marked thickening of Decimase membrane. And you can see a age-matched cornea, a normal cornea compared to one with CHED, where you have a very thin Decimase membrane, abundant endothelium. Here, a very thickened Decimase and a very attenuated corneal endothelium in CHED. So I think Murli is going to talk a little bit more about corneal keloids. I just wanted to make a few points here. I've looked at several specimens of corneal keloids in Chicago and also with Murli, and it has an interesting, some interesting clinical points that can be made. So these are lamellar keratoplasty specimens, and you can see there's this very sharp demarcation between normal and abnormal stroma. So the stroma can be very loose, such as this, with very plump-looking fibroblast-like cells. So one of the questions is, what is this tissue, right? Is it cornea, or is it, sort of abnormal collagen type 3? How does it behave? What is it? Then you see another phenotype of the cornea where the stroma of the keloid is much thicker or mature. The scar looks mature, as you would see in the pathology, and this would be more of a whiter scar. So lots of different types of changes where you see this loose connective tissue, more vascularized tissue, but always a sharp demarcation zone between normal and hyperplastic scar. So this is the take-home point here. So number one, this is the junction between the keloid and the normal cornea. And again, keratin sulfate. So the hyperplastic scar is not fibroblasts from elsewhere. It really is the corneal keratocytes that are activated that form the hyperplastic scar. The fact that they are producing keratin sulfate just like the normal cornea. So that's point number one. Point number two is, and you can see this across the spectrum of hyperplastic scars. The second interesting thing is if you look at, myofibroblasts express the protein smooth muscle actin. And here you can see the brown stuff is smooth muscle actin. This is the normal cornea. And this is when the scar is loose. They express these molecules inside the scar. But interestingly, if you look at the more so-called mature scars, and you can see that even though the cells look really plump, they don't express the myofibroblasts. So after a while, they quieten down, the cells. But at the junction between the keloid and the normal stroma, you see expression of these myofibroblasts. So the question comes is, okay, well, these are the ones that are probably going to produce a keloid. Should you be taking out a larger piece of lamellar tissue when you take out, the cornea, or you excise the scar, do a lamellar keratoplasty, and take out these myofibroblasts out of the equation? So MPS is another interesting disease. This is, I think, a typical picture, courtesy Dr. Murli. And if you look at the cornea itself, it's also very interesting. Number one, it is very, very thick, as you can see. And if you stain the corneal cells with Alcian blue, you can see expression, accumulation of mucopolysaccharide in the cornea. So unlike macular corneal dystrophy, which kind of does the same thing where you have deposits of mucopolysaccharide, these corneas are like 1,000 microns, 800 microns, and for glaucoma people, they can be hard to manage. You don't know what's going on. Discs are normal, pressure is high because of a thick cornea. On the other hand, you have a patient with macular corneal dystrophy where the cornea is thin in those patients, right? So, it's another interesting disease. So coming to congenital glaucoma, I think we've kind of spoken about this already, but I think Dr. Sushmita nicely pointed out the issue about the utility of imaging and looking at diagnostic. But the point I wanted to bring out here about the Hauptstria is that when, of course, when we see specimens in the lab, we're looking at end-stage disease. But the point is that these corneas do lose endothelial cells, you know, when these breaks happen, and they do decompensate over time. So I think that's the point to realize here. So we touched upon this again, but I think it's worth emphasizing that a lot of these angles don't. And I have some eyes from other conditions which I didn't bring, like aniridia or just very, very severe PCG, and the angle just doesn't form. And that kind of explains why probably tube-like procedures are a better choice in those patients. I wish we had better ways of imaging pre-op to be able to tell which ones to approach in which manner. So in conclusion, we have unique features of the developing and pediatric cornea, and I would urge young people maybe to work a little bit more on many aspects of the pediatric cornea. And the pathological features vary among causes, and I think once you understand the features, I think it'll be a key in developing new therapies for these group of conditions. Thank you very much.
Thank you, sir, for a lucid presentation, and you showed us what's happening at the cellular level. Are there any questions to Dr. Deepak?
Can I ask a question?
Yeah, go ahead, please.
Is there a difference in the primary pathology of the keloid in patients who don't have recurrence versus those who have recurrence? Is there a way in which pathology will guide us saying that look for recurrences in these kind of patients?
The short answer, I don't know. Yeah.
Just a not related to this, but a cornea question in the sense, why are aphakic children, what happens to the cornea? Why does it become so thick and rigid, even if it's clear? That's a question with the IOP measurement, which is always troubling.
So, like I said, we don't understand the behavior of the pediatric cornea, you know, in many, many ways. And so, you know, why some of these corneas are thicker and why they behave that way, don't know. No. So. I've asked Sonam to do pachymetry before she does the cataract. Right. And 3 months down the line, those corneas are not only thick, but they're also very rigid. So when they sent to us with the 28 mm mercury and the disc, so the disc is the only thing that we have to follow. Yeah. What happens? Yeah, so the behavior, the response, I think is different. And I think those who do pediatric cornea know that. I mean, one thing I can tell you, we've done a study looking at the cross-linking of the cornea in children. The cornea is not cross-linked at all, the collagen in children. And that's one of the reasons why when you try to hydrate a paracentesis, the wounds don't close. That's why you had to put a suture. And that's because of very, very poor cross-linking. And so as we age, we cross-link. And we see that in the sclera, how it behaves, right? When you try to do a trap flap, and junior resident is horrified when they see the sclera kind of curl on itself and become shorter. And that's the lack of cross-linking. So that we know for sure.
Is there a term, intrauterine infection affecting cornea? Is that at all an entity causing unilateral cause of because I many times that seems to be the diagnosis of exclusion in many of the.
Theoretically, it's possible, right? I mean, you can have organisms cross the barrier and do that, but why specifically the cornea? I mean, often.
Has it ever been proven? Because I have not read so much of the pathology, so okay.
Not that I know.
So that's good enough for me that if you say so.